Okay.
Great. All right. Well, welcome everyone. Thank you for joining us in our series of Buncke Clinic virtual visiting professors. I am Bob Aksafa, and on behalf of Greg Buncke, Rudy Buntick, Andrew Watt, and Walter Lin, and myself, I'm going to welcome you all. Tonight, I had a distinct pleasure and honor to introduce a very good friend of mine, Dr. Amy Moore. I've known Amy for many years now, and I've kind of watched her kind of really take off from a career standpoint. She is the chair of the Department of Plastic and Reconstructive Surgery at the Ohio State Wexner Medical Center. Amy is truly a surgeon scientist. She spent many years in her early career at WashU, and she's done a tremendous amount of work in both basic science and clinical nerve research, and she's published over 100 peer-reviewed journals and chapters. She has secured over $1 million in DoD grants and so on. So she truly is a combination of surgeon and a scientist. She did her training at WashU and peripheral nerve fellowship at WashU, followed by a hand fellowship at Mayo. And then she went back to WashU, and she recently moved to Columbus, Ohio. Unfortunately, last year during my travels, I missed Amy when I went to Ohio State. She wasn't there yet, and I missed her when I went to WashU. She had already left. So I missed her twice, but I've been to WashU and hosted by her before, and I look forward to hopefully visiting her in the future when travel is available. As I mentioned, Dr. Moore is very well recognized throughout the world as an expert in peripheral nerve. She's given many panels and expert talks. Here she is at ASSH, given a talk. I think this was in Boston, if I'm not mistaken. And speaking of ASSH, she was a 2017 visiting professor and the 2020 Bunnell Fellow. Obviously, with travel being restricted, I think she'll do most of her travels next year. We've traveled to the same meetings all over the world, and here she is giving a talk at the Gilbert Symposium in Paris. And she also was given the 2019-2020 PSF Foundation visiting professor as well. So clearly a lot of accolades at a very young age. So I think it speaks to her talent. And Amy, really a pleasure and honor to have you here with us. And I'm going to give you control of the screen here. Give me 1 second to find you in this list.
Thank you, Bob. The good news is I had different outfits on in each of those photos. I was worried. I'm like, oh no, I'm wearing the same thing every time. But no, it's such a pleasure and honor to be here. Let's see if I can get my screen going. All right. How are we looking? Okay, Bob?
Perfect. It looks really good. And I'm going to ask everyone to keep their microphones off and their webcams off, including myself. And we'll turn the cameras and webcams on.
All right. So thank you again for having me. And I'm going to talk about nerve transfers with a new indication. And so I do have a few disclosures. One, I'm a research collaborator with Checkpoint, but has nothing true to what this talk is about. I do need to thank Scott Cozen and Dan Zotolo, who helped me get involved with these patients with acute flaccid myelitis, as well as for sharing their patients with me. And then the parents of my patients who have given me permission to show their faces, show their outcomes, and to tell their story. I do want to acknowledge the PSF, which is also a reason why I put this talk together in the first place. So acute flaccid myelitis, I'm going to start with just giving you a background. Many of you may not even know what this is. It was first recognized by the CDC in 2014, and it is termed the polio-like illness. It's affecting predominantly children. However, the oldest that I've operated on is 39, but the average age through the CDC is about 6.4 years. The problem with this disease is that it attacks the anterior horn or the motor central part, so sensory is usually spared, and it's following this every other year pattern. And so that is also associated with a viral illness. These kids they're completely healthy, they get a respiratory infection, and then within 5 to 7 days of the fevers, they become paralyzed. It has been only 7 states that haven't had any cases, and even on an off year, 2019, so it's 14, 16, we're getting ready to start 20. Who knows what 20 is going to bring us with coronavirus around? Maybe it'll diminish this because people aren't socializing as much. You have to forgive, I think I have my kids in the background, which you're probably going to hear yelling. But the viral etiology is what was associated with enterovirus D68. D68 has that same every other year peak, which is why there's this association. Although these kids get spinal taps, but only 5 of these cases have been positive. And so really it's coming from a bit of an unknown, and there's lots to learn from this disease, very similar to, unfortunately, the pandemic we're experiencing. They do believe this D68 is the culprit, but again, you could have a whole family get sick, but only one of them have attacking this spinal cord with paralysis. And when they put this into an animal model, they're able to show it doing similar phenotypes. And so there is this thought, if we can get a vaccine to enterovirus D68, that we would help with many of the children who have been affected and help prevent that at least. Currently, the CDC uses MRI as its confirmation. The problem with that is that if the kids who come into the ER who are very sick, paralyzed, often needing ventilatory support, the MRI isn't positive yet. And so they're finding that the MRI doesn't get positive for 5 to 7 days, and oftentimes it can be missed. So there's probably an underdiagnosis or recognition of this disease process. So what is the clinical picture? Here are, that's gonna just jump ahead, but that's okay. Here is Scott Cozen with one of her patients, and you can see, unfortunately, the clinical paralysis is affecting the proximal muscle bellies. And so the arms, we don't have the typical spinal accessory to use for nerve transfers because it's wiped out the trapezius, the neck muscles, the shoulder and upper arms, but the hands are usually preserved. And as you can see here, there's multiple limbs involved. So it's patchy involvement and pretty devastating. What's a little scary and why the parents of these patients tout this as polio or some version of it, although poliomyelitis, the virus, has not been obtained from these kids, is that they have the same phenotype. So if you see this patient who was treated at the Shrine has the exact same features as my patient who's here on the right. And so that's the part that's really scary, is that this is a frighteningly devastating disease, and prior to not having any intervention. Pharmacologic treatment, these kids get inundated with steroids and plasmapheresis, IVIG, but with very little impact on their outcome. And I'm gonna go back to that because this is a little bit of a long video, but I've timed it well. So you should be able to hear it and it will work out. This is the grandmother of one of my patients, to give you a perspective of how devastating this can be.
Typical. She was just a happy, vivacious child, always running around playing. And, you know, we had gotten the diagnosis that she had the bronchitis. Came home from the hospital after treatment, and the following day, you know, it was like any average morning. We woke up, she was running around, she was jumping on the couch, she was playing, I was getting ready to leave. You were in the kitchen cooking her some breakfast, and in a flash, our lives changed forever. Kimmy jumped from the couch, went running into the kitchen to see what you were doing. And her legs just like a little marionette doll, just collapsed from under her as she was turning the corner. I watched this in disbelief, and she jumped back up, and boom, they just collapsed from under her once again. Well, we were there at the local hospital there in Temecula, California. Once the doctor had a good look at her and sort of went over things, she realized that what was going on with County was beyond her expertise. And so right away, she was on the phone making arrangements to get us to the hospital there in San Diego, everything started to really happen and progress really fast for this virus, acute flaccid myelitis. It was approximately 15 hours. Cam's body began to shut down completely. She was paralyzed from the neck down. What was worse is that her diaphragm completely shut down. In fact, it affected every major organ in her body. She was dying. She was fighting for her life, and I'll never forget you calling me and telling me that I'd better get there because it wasn't looking good. And even though you didn't say that she was dying, I knew that she was.
So pretty emotional video of just to give the perspective of the parents and the grandparents who are treating these children and this vulnerable population that we need to come up with how we're going to help them and what can we do as a plastic surgeon, as a nerve surgeon, and what do I know best? And that's nerve transfers, right? So when we don't talk about nerve transfers, I'll go to a little bit of the basics of it, but at Washington University, I grew up with Susan McKinnon learning about nerve transfers, and in my mind, every nerve injury, every paralyzed limb, I always think about what can I transfer, what's nearby, where are my donors, and have effectively treated patients with nerve injuries across all from head to toe. And so this was another patient population, a new indication, but could I apply these principles to them? So when we think and talk about nerve injury, I think it's important to remember our basics, that the motor neuron provides the axon, the nerve can be injured, and then there's a systematic series of events that occur that allow that motor neuron to project its axon to its muscle or skin as the target organ. And unfortunately, in adults and in humans, it's a millimeter a day, an inch a month, a foot and a half a year, and a little faster in children. Slower in spinal cord injury, and I would tell you ahead of the time that's slower in acute flaccid myelitis as well. But if we think about how we've treated nerve injuries in the past, we could do nerve grafting, and then nerve transfers themselves were born. But when we think about our function of our patients, the key is to intervene in a time before that muscle undergoes irreversible atrophy. And so that's the concept around why and how nerve transfers came to be. This is a study by Tessa Gordon, and she's genius. Did most of her studies out of Edmonton, is now in Toronto. And in this study, which we refer to it tells us that you can lose up to 70% of your motor neurons before there is a loss of function. And when we think about this curve of where people are with their degree of injury, our goal isn't to have 100%. We don't need a one-to-one relationship of number of fibers to function of the donor and recipient. We just need to get patients back on the curve. So thinking we can get 30% of reinnervation for function, that may be all we need, and not looking to do the home run. And I feel that it's because of this science and this understanding that we do have unprecedented outcomes from nerve transfers. So what are our principles? They're very strong, right? A donor goes into a recipient, it's redundancy of function, it's expendable, and hopefully the nerve that you're taking, that's the donor, is closer to the target. So we're going to decrease that regeneration distance and effectively increase the speed to which that muscle will receive the input. And that's the concept behind nerve transfers, and it's the principle that's holding true. And that, again, I'm going to apply to a new indication. So here it is, the outcomes. This is why we think nerve transfers are really has had a sticking. It's because that we're seeing unprecedented results. I love taking selfies. I've taken many selfies with many of you who are on this call. But I finally put one to use. So here's Christoph Oberlin, and the nerve transfer that I bring up is for elbow flexion, because in 1994, he published his results on a ulnar fascicle to the biceps and showed that M4 improvement. Susan later in that same year published her results of using a double fascicular transfer to restore function, and again with MRC grade 4 or above function. And I bring this to your attention because we have to think about fascicular anatomy. And later when I'm getting into the sciatic nerve, it was based off of the principles that we know from this strong nerve transfer. Can I get into the fascicles of the sciatic nerve? And is there redundancy of function that I can use them to transfer to a more needed muscle group? And so it is knowing that the fascicular anatomy is very consistent, and this is the case in the upper extremity. And here it is intraoperatively. It's sort of an ugly picture with all the blood. It should do better, but can get into the nerves, not take away function, or have a donor deficit, and restore muscle function. And in this next slide, as I'm trying to click it, I'm learning that if I double click it, it goes too fast with these videos. So to bear with me. But you can get MRC grade 4 plus. That's what I expect from that nerve transfer. Doesn't matter how big your patient is. Doesn't matter if they don't show up to therapy. You can get it because it's a synergistic transfer and easy to restore. So when we think about 1994, when Dr. Oberlin presented his results, and we see this exponential shift of interest, and of those, the majority are of the upper extremity. And recently, we're seeing it now moving into the lower extremity, which is what I've begun to do. And even less is that there's 4 publications in acute flaccid myelitis. And so this is the realm where I am right now, these two, and pushing the limit of where nerve transfers can do. I mean, that's what we as plastic surgeons, hand surgeons, nerve surgeons do. It is to push the boundaries and innovate. And I love what I do, and I'm very blessed to do what I love. So when we think about nerve transfers with acute flaccid myelitis, I'm now just going to go into my approach and my thought process, and how I was able to help these children. So here's Miss Lauren. So for an upper extremity function, you can see her right side is flaccid at the shoulder and elbow. She's gotten a better recovery of her left arm, and she has good hand function. And she was from my 2018 cohort, and with some triceps, which is actually quite rare in these kids, but thankfully she had it. So at 7 months from her diagnosis, I took her to the operating room, and this is where, again, it's sort of use what you know and apply the principles that have been founded for the upper extremity for brachial plexus, and use it. So I did an ulnar to biceps nerve transfer here. I did the triceps to axillary, but I didn't have spinal accessory for suprascap, and I didn't have intercostals because she has an elevated diaphragm although not ventilated. And so I used a median fascicle to the suprascapular nerve way up here, went into the anatomy lab and was able to, under the pec, find that suprascapular nerve there. And so again, just getting into the nerves, finding the fascicle even way up here at the cord level and being able to transfer it. So early results, let me try to get us there. Let's see, come on. For her is, you can see she's trying to figure out her donor for her ulnar nerve, and she'll eventually get it. There it is, and she can hold it. So early at 6 months for her. And then for external rotation, that one was a lot easier. So she knows if I just squeeze my hand really hard, I can get it to externally rotate. And that's exciting when we don't have really any other muscle group at the shoulder doing it. And so I'm excited that this was an outcome from just using principles that we know. And here are the case series that have been published thus far for acute myelitis. I'm almost out with my series of lower extremities. So why lower extremities, and what can we do from this? So when I started at Washington University, everybody was already doing nerve transfers for brachial plexus or for high nerve injuries. And I worked with Tommy Tung, and we did many cadaver studies of let's use nerve transfers to restore function in adults and after trauma. And so I was able to, again, apply these principles and restore gastric function from using branches of the femoral nerve. That has also prompted me of being like, okay, well, of course, I'm going to look to options for these kids. And this is where Dan and Scott come in, because they've been, at the Shriners Hospital, which is has a history of treating polio. They were seeing these children and asked me, do you think there's anything you could do for them for the lower extremity? We know that's your passion is. And because I had no intention of them sending me the patients, of course I was just said, oh yeah, we can do a sciatic transfer because the fascicles should be there because their toes are working. Again, this patient population has the proximal weakness, but the distal is intact, such as the hands and the toes. And so the idea is that the sciatic nerve would probably have the same fascicular topography as the upper extremity, and so why couldn't this work? And then they said, okay, well, that sounds great. We're going to send them your way. And I was like, well, okay, here we go. So through a lot of discussion with the parents and others around the country to say, okay, is this crazy? So here is Cammie. She is the one with the grandmother was talking to her dad. She can use the left leg pretty well, but on the right, all she has is a bit of toe motion. And the goal was to restore her gluteal function as well as her femoral nerve function. Here is Reed. Reed has a similar issue on the right side, but he lacked hamstring function, has hip flexion that was good, and you can see he's trying to kick his dad, but he uses his intact left side to do it. So flaccid paralysis, but you can see those toes are working just fine. And so I said, all right, well, I can steal from this. If you don't have toes motion, do we really lose anything? And if you have toe motion preserved, but you can't stand and shift your weight and come and transfer yourself out of a wheelchair, then what good is that toe motion? And so that was the mindset I had when approaching these patients. So I used sciatic fascicular transfers to restore gluteal function in some patients, femoral nerve function in others, and hamstring function. And I'm just going to briefly touch upon these. And these are one patient and this is another. So intraoperatively, you can be up at, then this is from a femoral nerve. I can find the sciatic nerve with the arm, the leg externally rotated. Here, I'll see if I can speed this up. Not really, but I'm up at, well, Always using a stimulator to make sure there's donor, but we probably didn't need all that music in the background, so forgive me for that. But the long and short of it is you can get that topography of the sciatic nerve way up at the gluteal muscles. And so for restoring femoral nerve function, you have this crazy start prone, we find the sciatic nerve, identify the fascicle within that you're going to take, as well as ensuring that you're going to leave behind enough. And then you can bring the femoral nerve from this incision here through the thigh, right adjacent to the femur with just a subcutaneous tunnel, and you have plenty of length. And so I targeted vastus medialis, which has the longest length, vastus intermedius, and every once in a while I could get rectus femoris. And so they pass through from anterior to posterior to then get to the donor, because the donor is short. And so that was what we had to sort of create. Here is for gluteal nerve function. I used the guidelines from an SGAP to initially do the approach, and a couple of cadavers later figured out, okay, I can, because these muscle groups are really denervated. I focused on superior gluteal nerve because of the medius muscle being one for stability of the hip and pelvis and preventing rotation and allowing for you to stand. And that came from polio work in the past. So we were able to get in and do a direct end-to-end to the superior gluteal nerve on these patients. And this is a different patient where I used sciatic fascicles to restore hamstring function. Proximally, I used the toe extensors for its glute and then toe flexors for hamstrings. And there you can see that it's tension-free. All the principles that we'd otherwise think about in the upper extremity, I've just been using in the lower extremity. And so here is Reed at 7 months. It's a bit of a graphic image, but he's flexing his toes, and you can see his hamstring fire, but he had no gluteal function. And then here you can see his little bottom squeezing. And so this is really exciting to see. This was early on, and then getting almost against gravity with his toe flexion. And so I think that with these children from the 2016 cohort, I recognize that we can use these principles of upper extremity and restore function to these children. Brandon was one of the first that we did, and he's the one that has brought the most attention and a public awareness to the US. And at 2 years, he was in a wheelchair when I met him, and his story is profound if anyone ever Googles it, because he'll talk about how his life not being able to be near his classroom on the second floor because there was no elevator, and it's just heartbreaking. But here he is 2 years later, and he's only in his wheelchair to play basketball. And so I think that although he's still in a brace, I haven't restored perfect function, but he came at 10 months from diagnosis and walks now. And so that is an exciting part, which still brings tears to my eyes. And so what did Brandon's recovery and their mission is that it changed my life quite a bit, but more in the focus of what we can as surgeons do for awareness for our patients. I didn't know that being able to talk to the media and what impact that would have until you have all the parents thanking you, saying our kids deserve this attention. And if they would have probably known sooner, they could have had the intervention to restore function for their upper extremities or their lower extremities. Dan Zotolo and Scott Kozen are reinnervating the phrenic nerve. Alan Bellsberg is doing that as well. And so this attention has nothing to do with ego. It has completely to do with what we can as surgeons and as physicians do for our patients. And that's the humanity of it. And so when I just finish up with talking about my series of what I thought, my thought process of going from having no idea it would work and trying to, so basically every day making it up and knowing that each patient had a different set of muscles affected. And so it's such a cerebral great thing of nerve surgery is being able to just go in and be like, okay, well, we're going to take whatever's strongest, we're going to use what you can have, and we're going to try to restore what we think is important. And so that was where the Taylor transfers come in, which makes it really hard to publish because it's so diverse. But here it is written out. I did 13 patients from the 2016 cohort, 10 with lower extremity, average age of 4.3. The youngest was 19 months. But time from diagnosis, 14.9 months. These kids came to us late in this 2016 cohort, and 2018, we were much better at it. I operated on 33 children with 10 months from their diagnosis. I think the ideal time to intervene is between 6 and 9 months. What is the focus for these lower extremities? I think gluteal function and stability, with glute medius being reinnervated. Knee extension comes second because it counters the forces, and then knee flexion. And all of the nerves that I innervated, I decompressed at the same time. These children did have a lot of pain as well. And what's great to note is that even with taking toe and trying to be aggressive of how much of the fascicle, of the fascicles that I was taking, there was no patient who had to downgrade in function. They maintained their toe motion beautifully. And so here's some early results from the upper extremity for a sets transfer that when I intraoperatively, once I got in.
Slide your arm.
Oh, I'm sorry, I didn't mute it.
Slide your arm to the side. There you go, and then bring it back down. Yep, and do it again.
And so not against gravity yet.
Did before? Yeah. Yeah, try it again, one more
I
time.
was leading the audience there, I was leading.
Good job. And then can you raise it all up at all?
Let's see.
Now.
Get it up and count.
Okay, let's do it.
1, 2, 3, 4, 5, 6, 7.
So shoulders are hard, but if I got in where they couldn't move, I decompressed them, and maybe that's all they needed.
Okay, come up slowly. Can you rise it up slowly? Very good. Oh, yeah.
Okay, well, there's that obnoxious sound. I'm so sorry about that. But really happy to see it early. 2016, 7 patients with follow-up of this, of the 10 of lower extremity. And I can tell you that none of them are normal, and none of their muscle grades were consistently 4. A few were, and but what's important to me is that 5 out of the 7 that I've had follow-up are ambulating with braces. And I think that alone in a child is a great thing. And although it's a mixed bag of what that means to them, I am glad to see something and hopeful for even more over time. And so here is Cami again. This was the grandmother talking, and this is one of her grandmother's emails. So this was with her early trying to walk.
Good job.
Spontaneously standing, muscle mass. But the key part of this group tells you the bankruptcy, right? So that all of the financial stress that these families are faced with made it really difficult to do follow-ups. And I'm so excited about televisits and telehealth of COVID, because it's allowing me to get the follow-up as I need to do and see these patients. So that's been one benefit of coronavirus. And so this here is Joe. He's another 15-year-old who was always walking with crutches, unable to move, restored his femoral nerve function. Here's Alfred. He's also able to see that he had the transfers for femoral nerve with recovery. And so here is Miss Cami most recently. So again, not normal,
Straighten out.
but being able to stabilize through. The bracing may be all it is, but she came to me at 14 months from her diagnosis in a wheelchair without the ability to stand And so this is a huge change in their life after having a year of the inability to walk. So I think the exercise tolerance, the increased tone, although not normal, is doing something. And the Sterling Bennell quote comes in March. Those with nothing, a little is a lot. And so this last video, and then we'll be done and I'll take questions.
Some are calling it modern day polio. It's not talked about much. There is no cure. It's AFM, Acute Flaccid Myelitis. It affects hundreds of children each year. AFM can attack the healthiest of kids, and knowing the signs can dramatically change the health and welfare of your child's future. AFM can cause paralysis in the face, arms, diaphragm, stomach, and legs. The CDC is currently working on finding out how children get AFM and possibly a cure. All it takes for children like this to get help is you. Help raise awareness for children already affected. Prevent it from happening to someone you love. It takes a team to fight this virus. We can't do this alone. It takes determination. It takes courage. It takes perseverance. And it takes endurance. It takes strength. It takes hope. But most importantly, it takes love to fight this virus. We will spread awareness. We will find a cure. We will rise. We will stand. We will walk, run, breathe. We will keep moving forward. So what now? These children aren't asking for much. All they want is to live again. And all we want are answers. Help us share their story. Help us raise awareness. Help us find those answers.
Thank you.
Wow. Amy, thank you so much. Really an amazing talk on a topic that many of us don't know too much about, which is why it's such a great talk to hear. I want to congratulate you on, it's not very common that you get to innovate in a completely new area, right? And do operations that either haven't been described before or just apply to something completely new that we don't know too much about. So I really want to congratulate you on being a pioneer in many things, but especially in this area. And I think for all of our viewers, this really underscores the importance of the importance of continuing to learn from cadavers. I think you're never too old or too seasoned to get into a cadaver and try to figure out the anatomy and see if something's feasible. And I think, it's quite obvious that you did your homework on a lot of these transfers to kind of see how it's going to work and where should you route the nerve to and all that. So again, congratulations to you on that as well. And for those of us who were at ASPN in January, if you attended the ASPN conference, Scott Cozen gave an absolutely touching talk as a keynote lecture on mostly the upper extremity stuff, and it was really, really incredible to see. And I think you're making some amazing contributions to these patients' lives, and the fact that they're children, I think, makes it even extra special. So congratulations on that. I have a couple of questions, and then we'll open it up to the audience. So obviously, a lot of us have done upper extremity transfers, and very few of us, if any, have done lower extremity. When you're transferring these, nerves that control toes and the foot and so on, do you have any idea as to the axon count ratios of these nerves to the nerves that obviously are innervating, the hip muscles and the knee and so on?
So I took a bunch of samples from the 2018 cohorts, and I will know those numbers eventually. It's hard from our histomographer to do them. But when we took it for the previous lower extremity, they were about 1-to-1. Like the obturator nerve is a little less than those of the quadriceps. And so I expect that the donors are not going to be equal 1-to-1, which is why I think if we can just get tone is why we're seeing enough, because if you think about all the muscles that stabilize, going into 1 or 2 with not as strong of a donor, my expectation for the parents as well as for myself was this, we're just trying to get tone. So I don't know that direct answer. I hope to have it because I do have a bunch of in the lab. It's just priority and expense.
Yeah, I think the reason I asked that wasn't necessarily to say, oh, there's the axon count, there's a mismatch, but I think it goes to your point that to someone who doesn't have much, a little bit, it's a lot, right? So basically, if even if the axon count is off, I mean, even for the AIN to ulnar motor end to end, the axon count is not 1-to-1, and you're innervating many muscles with one nerve, but it almost doesn't matter because if you don't have much function or no function, even getting that little bit of tone is a tremendous amount. So I think, so I think that's. Yeah.
I'm just thinking it's a balance, just enough to balance the action.
Yeah, exactly. Now, one question I had was this obviously being a relatively new kind of diagnosis, if you will, or at least increasing numbers recently. A big challenge of this is educating the public and other physicians and other hospitals in other states. Have you found it very challenging to get the word out to other practitioners around the country or maybe even around the world to at least get these patients to you in a timely fashion? Because I would imagine that's probably one of the hardest parts of this.
Yes, very much so. It is worldwide. So I had a lot of patients wanting to come, and they were fighting against a year, like right after a year. And so getting the word out was what I felt so impassioned about once I got results. And I think that was sort of a comical story behind it, and then I will get to the point. But my patients were getting function, and parents wanted to make awareness because 2018 was another year. So I had not gotten any feedback from my patients because of the expenses, and I was like, well, come back if I can help, see these local providers, and if whatever, we'll go from there. And then it was one of the patients was on the news in Florida, and they said, oh, our physicians in St. Louis did our nerve transfers and my daughter's walking now. And so it happened to be that they finally found me that way. And so then it was, okay, it is needing, if I'm gonna have a result, then I really want to get this out as best I can. And that was really pushed by the parents. The parents found all these avenues for where I could speak to, here is what we can do as as surgical option for which these kids thought there was nothing for them to be able to be done. So I do think that that is still a limitation, and how rare it is that if we're thinking like 100 to 200 patients diagnosed every couple of years, it's hard to do a push into the emergency room, physicians to say this is something you have to know about when you may never see it in your career. So it's a little bit of balance.
Yeah. Hey, Amy, Glenn Gaston here. Can I piggyback one quick question for you on that same topic?
Hey, Glenn, how are you?
It's good, Babak. Amy, great job. Hey, I
Thank you,
may
Ms.
have stepped away and missed this one comment, but I saw you said the ideal time is about 6 to 9 months, but a lot of years are pretty far out. How far out would you say you would no longer offer nerve transfers in these? Because is it really the same as a peripheral nerve injury? So what's kind of your upper limit?
Yeah, so I will be honest, I operated on a girl who was almost 3 years out, and more so for the decompression than it was for the nerve transfer. And her parents assure me that she walks differently than she did. And it was for gluteal function. I know that the difference with these children is that their sensory organs are still intact. And so the afferents that are hitting those muscles are present. And many of us believe that that window pushes us out longer. And so I like these kids who are walking, the average was 14 months. And so I only had 2 children who were at 10 months, and one of them wasn't walking because they were globally on both sides. But they were late and they still got return of function. The reason why I'm saying earlier now is that what we've been able to track is that if by 6 months they don't get motion back in that extremity, it's not coming back. And so what I fear is that people are intervening too early to not see that natural history, and we don't have the natural history of these patients born out yet. And so my ideal window would say, you know, the later the better, but not too soon.
Awesome,
Great.
thanks.
I don't know if that makes sense.
Thanks for that. Greg, I see you on. Do you have any comments or questions for Amy?
Amy, it's so nice to see you. Thank you so much for doing this. This is really wonderful. You're obviously, you're doing a great job, and it's so nice to see that you're now a big shot in Ohio State. Congratulations. It's really great, and we're really rooting for you and look forward to hearing about all your progress and seeing you at meetings and actually seeing you here. I think this has been fantastic. Do you has this become the biggest part of your practice now, or what are you doing mostly?
It was, no, for sure. It was for the last year because, and before I moved to Ohio, it became inundated with the children. Once they got to me, it was like the time was on. And so these cases are long, and so I was doing 2 to 3 of them a week to try to get them done in a timely fashion. I evaluated over 50 children and then offered operations for 30 something for the 2018 cohort. So a lot of cases done in a short amount of time. But I don't know what 2020 will bring us. I mean, I think this is why I've sort of been trying to talk more about it even recently, is because we all as nerve surgeons may be seeing these patients as 2020 outbreak is upon us come August.
Well, congratulations. It's great work. Thank you.
Well, we'll see if this is what it does. I mean, it's like an every other year kind of push, but we'll see.
Yeah. Great. We have a question from one of our fellows, Danny. Danny, are you there?
Yep, I'm here.
Great. Go ahead.
Dr. Moore, that was incredibly inspiring. I've got 2 questions. My first is, you know, we've learned a lot about nerve recovery from these polio patients, and my question from you is, you know, obviously you want to give the muscles as long of a chance to recover, or the nerves as long of a chance to recover before intervening as possible, but not so late that it's too late. What did we learn from the polio patients? Is it really, if you get nothing by 6 months, it's time to move on? Can we take anything from sort of the polio experience? And my second question is how you're showing extraordinary outcomes in kids. I'm wondering if you think we can translate this to the adult population after trauma, and after if whether these sciatic transfers can be used in adults.
Yeah, so I'm going to answer your second one first. So I have done sciatic fascicular transfers on 2 adults that had their femoral nerve resected proximally for cancer, and have been able to get back M3 results from it, but I can't say it's just from the sciatic nerve because I also did an obturator transfer. So I have to put that in there as my caveat. And the femoral nerve, I truly believe that we have to put everything in it to get the stability of all those quads. But I have two patients. One is too early, but I'm certainly confident in the technique with it. That why wouldn't it in an adult in trauma if we just think about fascicles, right? So that I can tell you that. And then the first part about polio, I read a lot of this literature before I went to the operating room with these children, more so to see, okay, what was ever done for these kids. And there's been a couple of reports of free functionals to restore the glute medius, which, you know, in Asia, that was a technique that was used. Tendon transfers are sometimes available, but using more of your external oblique and flipping that down. And unfortunately, these children are different than polio because their entire abdominal wall and core has been affected. And so those kinds of principles didn't quite relate. But what I did learn from the polio patients was that go to superior gluteal nerve, not the inferior gluteal nerve. Get stability of the hip first before trying to get the lower leg or the upper leg, I should say. And so that was that directed my focus, and it came from a physician, Neil Matthews, who was visiting us and said, well, I think you should go to superior because these are the patients that treat in polio in India. And so I felt that was something I learned from it. But unfortunately, you know, there was not much that was done for patients with polio.
Thank you so much.
Oh, you're welcome.
Thank you, Danny. Andrew Watt, you have a question.
All right. Hi, Amy.
Hi, Andrew.
You know, a couple people have suggested at various meetings that maybe we should just be decompressing all of these kids relatively early on to facilitate potentially spontaneous recovery. One is, do you have any experience with that? Two is, it makes sense to me that a nerve transfer is going to get reinnervation probably more expeditiously depending on when it's done. And then third, are you relying on some proximal recovery and going into side, or are you hedging your bets and going end to end, knowing that they may not recover from a proximal source?
Yeah, so great points all around, Andrew, so thank you. So as for decompression, I decompressed many children, 2 in my first cohort, only decompressed with no nerve transfer on one leg or another. So like, although it was only 10 children with lower extremities, many of those were bilaterally, but in some it would be one-sided, just decompressed. And my thought process behind it is what I believe is that these children get paralyzed. They eventually, their prodrome knocks out the entire spinal cord and they start to recover, but they're swollen. You know, the parents will talk about how swollen their children are, and then they're paralyzed and move. So the spinal cord is where the injury is. And we know after a nerve injury, nerves swell distally. And it's all about the space through which that nerve can fit. And so when I would push on their nerves, they would scream. And I was like, whoa, you're having pain? They're like, no pain. Kids didn't report pain except during their denervation period early on when they had the viral prodrome and were becoming paralyzed. They had horrific pain, again, not published, but they could press on me. And so by decompressing them, I have seen improvement where they were weak and now they have against gravity extension, and all I did was decompress. And so I do think that there was a huge role for that. I didn't decompress if they didn't have pain. And so I know Nath wrote about his decompression on a patient and got recovery. So I don't think it's the only thing to do. I think it is an option to be done. And so that's what I sort of think about the decompression. I know you had a second part of your question, but I got so excited about that first one, I don't remember.
Yeah, from a technical standpoint, when you're during your coaptations, are you going end to side, assuming there may be some proximal recovery, or are you going just end to end?
Okay, so now we're going to nerd out a little bit, because what's different with these children is that the attack is at the motor neurons at the spinal cord. And this was the hardest decision for me. And that's because it's not like a nerve that's recovering. So intraoperatively, a brachial plexus or a high nerve injury, if you stimulate that nerve, you're like, my hands are off, I'm going to go into side, because no matter what, that we know that the connection's intact in that trauma. These children, I could stimulate and get function, but I didn't know if it was ever going to get better, because it's the number of motor neurons that were attacked by the virus. And so I couldn't say, is this nerve recovering, or is this nerve what it's going to be, and that's the weakest it's going to be or the strongest it's going to be, because the motor neurons went from 100 to 50 or to 30, where we have some function but not enough. And so those I did into side. But what was interesting, and what I probably should point out, there's 2 girls that were going against gravity or starting to show their axillary nerve. I decompressed them, and before they had nothing against gravity. And so, or nothing movement. It was just sort of like motion, but they were so tender, and intraoperatively, once I decompressed them, they started to fire. And so that's why I went into side. But I think those girls are more a reflection of the decompression, and maybe not anything I did with my into side. Sorry, long answer, great questions. And what make these kids so, I've learned so much. I don't really know how useful it is outside of these kids, but it's fun.
Great. We do have a question from the comment section from Venkat, and he asks if you do any immobilization after lower limb nerve transfers. As we know, in nerve transfers in general, you typically have a lot of redundancy, or you should have some redundancy. So perhaps immobilization may not be needed as you would for a tendon transfer. So that's the first part of the question. And the second part is if you use any electrical stimulation in these cases to prevent atrophy of the innervated muscles. So,
okay.
I don't know the answer.
No, it's good. It's good. I'm going to try to keep these 2-part questions, man. This is good. So the first part is mobilization. So these kids have flaccid paralysis, and they can bring their feet, they'll grab their feet with their hands and like bring them over their knees, over their arm, like their heads. And so I would put them in a knee immobilizer, not because I was immobilizing the nerve transfer, but just to keep them aware that I don't want you moving your leg like that. And so I was protecting the 2-year-old from the 2-year-old, where they were grabbing their legs if they had use of their arms. And so that part is good. What's the second part of that question?
It was about electrical stimulation.
Oh, E-stim. So yeah, so there's another thing. So intraoperatively, I do electrical stimulation on these kids for 10 minutes because I showed it in our laboratory that it's effective and it helps. And it's based on data from Tessa Gordon and others in the 1980s that showed you can prime a neuron to regenerate faster and more efficient if you do electrical stimulation. So I did that prior to my nerve transfers. But I don't believe in these kids that the electrical stimulation distally or prior to surgery mattered because the connection wasn't there. The spinal cord connection to the muscle isn't there. And I don't believe that electrical stimulation of a muscle that's not connected to its proximal source matters at all. Post-operatively, I use it once they can trigger, like once they start demonstrating a flicker of muscle, then I use it for them to retrain, but not because I think it's helping the muscle.
Makes perfect sense. Thank you for that. Great. Any other questions from our audience?
How are you doing that intra-op nerve stim? Are you doing that with the checkpoint or with neurology?
Oh, not with neurology. I use the handheld device by my disclosure checkpoint at 2 milliamps and 100 at the 100 frequency, and I hold it on the nerve proximal to wherever I decompress or proximal to whatever I transferred, because you want it to go back to the neuron level. And so for 10 minutes, you hold it on there, and we showed it, and that's where many of those studies now have been published of our rat data. And my clinical trial will hopefully start soon to see if it bears out in adults as well.
Great, thanks. That's super exciting.
Excellent.
Yeah,
Thank you for
yeah.
that. Well, Amy, thank you so much for joining us. I know it's pretty late where you are, but I really do appreciate you taking the time, especially nowadays when you're incredibly busy with the move and the new department and the family moving out. So thank you so much.
Yeah, you're welcome. It's my honor. So thank you very much for the invitation, Babak. It's great. Thank you.
Great, thank you. And for the viewers who are still on, we are going to be posting these videos on my partner Rudy Buntick's website, microsurgeon.org, and we'll let you all know when they're up. And also, for those available tomorrow, we have Dr. Larry Gottlieb at 8 a.m. talking about microsurgery and burn reconstruction, and Dr. Rod Hintz at 5 p.m. talking about tendon transfers in tetraplegia. So hope to see you guys there. Great. Thanks again, Amy.
Great. Good. Thank you.
so much.
Bye.
Have a great night.
Yes, good night.
Thanks. Okay,
Bye.
bye-bye.